my good friends. So I'm going to keep it very brief. I'm just going to be speaking about something we first mentioned more than 10 years ago, and that was ray tracing for LASIK. And then given all the changes with Alcon and Wavelight, it took a very long time, but the product was finally born and has started being used in about 5 centers across Europe as a controlled launch, just to get the product going. So I thought what I might do is share the process with you, that you're ahead of the curve and you know how it looks and what it's about. And I thought I would do that. So can I share my screen with you? Is that okay?
Yeah, start sharing.
Right, here we go. So it's not very long. As I said, I'd like to get through this as fast as possible. I realize for you guys, it's pretty late. It's late in the evening. So yeah. Tell me if my screen has popped up for you.
Yes.
All right, fantastic. So listen, again, Hossam, thank you so much for the invitation. It's very nice to be with you guys. So these are my financial disclosures. The ones that have any relevance here are basically Alcon and Wavelight.
Yeah.
And so, you know, all of us do interesting work, and what's happened over the last probably 20 years is we've learned to do amazing diagnostics. But just something that's not always well understood is that whether you do a standard treatment, so that's a wavefront optimized or a aberration free, you do a wavefront guided procedure, you do a photography guided procedure, or you do a custom Q, no matter how personalized your diagnostics are, when you treat the patient, the laser thinks the eye that you're treating is Goldstrand's eye. And Goldstrand is a very interesting man. Goldstrand is the only ophthalmologist to ever receive a Nobel Prize. And he received the Nobel Prize in 1911. So, you know that laser only came out about 55, 56 years ago. It started as maser, microwave amplification by stimulated emission of radiation. 3 years later, they swapped the microwaves for light waves, and that's where laser was born. And up until now, every single laser procedure in the world, except maybe 150, 200, have been done using Goldstrand's model. So no matter how good our diagnostics are, the laser still does the calculation thinking we're treating Goldstrand's model. So what happens with a wavefront, no, sorry, with a ray tracing procedure is this device measures the cornea, it measures the wavefront, and it measures the biometry. And then instead of using Goldstrand's eye model to do the calculation for the ablation, it uses my eye model or Mohammed's eye model or your eye model. It takes your eye and from your eye generates a model and then creates a treatment specifically for you, not only on the diagnostic side, but also on the input side. How it's going to treat your eye, it assumes now your eye is not Goldstrand's eye, it's different. So the rationale when we started doing ray tracing in 2009, 2010, is when they first did that initial study, they said, okay, Goldstrand said the normal cornea is 43 diopters, and the normal eye has a length of 24 millimeters. So what the initial trial said was, you know what we'll do is we're going to choose eyes that are not like Goldstrand, which means we're going to choose patients with high myopia, they've got a longer eye. We're going to choose patients with some astigmatism, so they don't have a 43 cornea, they've got a more complicated eye. And those patients did remarkably well. They did very, very well. So you know what we might try and do? I wonder if we can do it. Mohammed, is there any, Hossam, is there any way that you can mute some of the microphones?
Yeah, there's someone who is switching on the TV beside the phone. Please, my dear colleague, can you switch off the TV? Yeah, or switch off your phone, the microphone.
So what we're looking at now is in this early phase is this procedure in the commercial market is now called INNOVEYE. And what we're looking at now, starting to introduce this into the market, is to see how does INNOVEYE work in any eye in the clinic. So it doesn't have to be a high myope, it can be any eye in the clinic. So that's what we're looking at the moment. Why will this? There we go. So I'm going to show you a short little video of how we get this data. So for any of you who have the wave light laser, you'll know you've got this menu. This is what the INNOVEYE looks like on the laser. On the left is the wavefront. We now go into the wavefront. We look at the wavefront maps. We decide, nah, we don't really like the fourth one. We'll take it out. For the rest, they look pretty good. These are the higher orders. So you can see the higher orders are very, very regular. So we like what they look. We'll use those three. Now we're looking at the topography, or the tomography rather. We look at those four maps. We like them all. You can see the mean deviation is very low. We can look at the posterior curve. We like what it looks like. So we'll choose all four of those maps. And now the last thing we're going to look at is the biometry. It takes 4 measurements. It does an A scan, looks at the signal to noise ratio. And in this case, we'll use all four. All four look good. It now generates a model for the eye. And now it does the calculation. You can see bottom left, the calculation is running. For the study 10 years ago, this took 6 hours. Now it takes about 20 to 30 seconds. And it does the calculation to generate the ablation. And there's the ablation profile for this patient. And what you can see here, can you see my pointer on the screen? Can you see my pointer or not?
Yeah, okay.
You can see the little hand.
Yeah, I can see the hand and the mouse, but the pointing mouse.
Fantastic. So this patient's, no, I don't want to do that. So this patient's subjective refraction was minus 425 minus a quarter. On the cornea, it's minus 423 minus a quarter. What INNOVEYE has found, taking everything into account, is the refraction is minus 426 minus 063 at 4 degrees. And so what you can do now is you can go and compare. So when we started out, so I haven't been completely thorough yet on what INNOVEYE does. So we know INNOVEYE takes the eye that you're going to treat into account in order to generate the profile. But the other thing that it does is it looks at, from the literature, what the effect is of different treatments biomechanically, as well as different levels of treatment on the epithelial remodeling, which means with INNOVEYE, you mightn't have a result that on day 1 is unbelievable, but you'll find as the months go by, the result is getting better and better and better, because now it's taking into account the anticipated epithelial remodeling. So when I first looked at this and I saw the 1 month results with INNOVEYE, I thought, whoa, that didn't look so amazing, because I'd forgotten it's 10 years ago. So what I went and did is I went and compared the results to ray tracing results 10 years ago. And in fact, INNOVEYE's results were looking at least as good. In fact, we're looking slightly better. So I'm going to show you just a couple of examples. There's a patient that we're not using INNOVEYE for, but I was looking at every case I do now, I look at INNOVEYE to see what information it's giving us. This guy had surgery many, many years ago in 2002, and he came back now and he's drifted back to 125, but especially on his left eye, not correcting well, only seeing 0.8. So this is what his wavefront optimized profile looks like for minus 125, minus 125. This is what his contour profile looks like. This is what his Oculink, so his profile based on the Scheimpflug looks like. The previous one was his profile based on a topographer, a pseudo disc, that's Scheimpflug. And this is what his INNOVEYE looks like. So they look quite similar. Now, what I really want to show you on all of those preceding ablation profiles, I'm going to show you if we take away the refractive element and we only look at the higher order aberrations. This is from the Scheimpflug, this is from the pseudo disc, and this is from ray tracing. So I take very, very big consolation that for someone who had a previous corneal procedure, where the corneal procedure is probably the source of the problem, when I now go and look at the higher order ablation profiles, they look similar. It just makes me think this device is measuring the proper error. So here's another case. On the left is the wavefront. On the right is the topographies. And over here is the biometry. So there's the wavefronts. They all look great. We'll accept them all. Here's the topography. They all look fine. We'll accept them all. And here's the A scans. They all look fine. We'll accept them all. And so we use this information to drive a treatment. So this patient over here, 41 years old, had LASIK recently. He was minus 775 and minus 725. His best correction was 2020. Now, you know, a couple of years later, his best correction significantly improved. His refraction's not bad, but he's complaining about glare and halos. So again, I wanted to see what would this look like. We're not using INNOVEYE for these cases. We're still doing it only for my hopes for the moment, but I wanted to see what it looks like. So on this patient's right eye, if we were doing an aberration-free treatment, that's what the plus 050 minus a quarter would look like. That's what a Scheimpflug-driven treatment would look like. This is what a placido disc treatment would look like. And that's what ray tracing would look like. So again, it's really measuring data that gives me a lot of reassurance that we're on the right track. Now, what's very interesting, what we've done here is we're only showing the higher order aberrations. But when you do a INNOVEYE procedure, unlike all of the other procedures, it includes tilt. So this is very difficult to believe. But from a refractive point of view and from a higher order aberration point of view, those two treatments are basically going to do the same thing. But an INNOVEYE treatment always uses tilt. So it means when you compare cases, you're normally going to find that INNOVEYE uses a bit more tissue because it's including tilt. And tilt isn't a higher order aberration, it's a very low order aberration. And that's what the 4 ablations look like. So I'm going to show you this patient. This is very interesting. So this is a guy, right eye is -1, minus a quarter, left eye is minus 0.75. So on his left eye, I do a wavefront optimized treatment, 16 microns. And I measure him on the INNOVEYE, and it measures 16 microns. And I measure him on wavefront optimized, and it's also 16 microns. And that makes sense. Normally we're doing 15 microns per diopter. So in the major axis, when you add the 0.75 and the 0.25, it's 15, 16 microns. But on his right eye, INNOVEYE wants to do 30 microns and optimize wants to do 20. So obviously the one eye did INNOVEYE, the right eye, left eye did optimize because we're learning, and both eyes get a very good refractive outcome. Time will show if the patient with, or the eye with INNOVEYE gets a better quality outcome, but we're still in the early phase. And then the last thing I think what I want to do, so my gut feeling for the moment is that I'm very happy with what I'm seeing so far, but I think the jury's still, it's early days, you know, and because the epithelium plays such a big role, we need more time to follow up. So we've had our first sort of MAB meeting, Medical Advisory Board, and everyone's happy with the results, but it's early. And from what we learned 10 years ago is we want to really evaluate these results at 3 and 6 months. I want to show you why quickly. Here's one case. This is the last thing I'm showing you. Here's a patient who is 54 years of age. She had LASIK many years ago, 18 years ago, for -750, and comes back in April, 3 years ago, with the left eye at -150, -1. Both eyes were something like that. And she says, well, look, let's just correct the one eye and she'll have some sort of monovision. So I decided to do it with a PRK. This was just at the time that we got our first epithelial mapper. So I was mapping people left, right, and center. So here's the right eye, epithelium 67 microns, take another map at 67 microns as well. The left eye 63, take another map at 64. So I'll show you those maps just to show you that these epithelial mappers are very, very repeatable. They're measuring well on the OCT. So now bear in mind, this patient on the left eye has a 63, 64 micron epithelium. So I do a PRK. Day 1, 2025, I'm thinking this is great. This is like I expect, it's perfect. Week 1, 2030, I'm still smiling. Month 1, I'm saying, whoa, what's going on over here? 630, that's not great. +1, +225. This makes no sense at all. This patient's totally overcorrected. But now I see the epithelium is only at 52 microns. So I think, okay, it's time for the epithelium. So look at what happened over time. I've got all the 6 months over there. And over the 6 months, the vision gets progressively slightly better. The refraction gets slightly better. And fortunately, the best corrected acuity also gets better. But I'm still not understanding what's going on over here. So the patient says to me at 6 months, I said to her, you know, I think at 6 months, probably things have settled down. And she says to me, no, I think it's getting better. I'd rather wait a bit longer. So we wait a little bit longer. And finally, at 8 months, we get a refraction of +1 plus 0.75. She's now correcting to 20/20. And I'm saying, okay, we can go back now and make a final adjustment. But I still don't understand completely why she's got this funny result. So look at this. Yes, month 2, epithelium is, I can't see it. It's hidden by something over here, but let me just take this out the way for a second. Sorry. So 51 microns, then 53 microns. Month 4, 54 microns. Month 6, 60 microns. Now look at this. At month 8, we're back at 63 microns. Now you may remember that this patient was 63 microns pre-op. So why aren't we now back on track? Here's the OCT showing a beautiful centration. Here's the wavefront showing very, very good measurements on the wavefront. There's the central area of height on every single wavefront, but again, very, very nicely centered. That all looks good. And here's the epithelial thickness with an average of 63 microns. But now I want to show you the power of epithelial mapping. So this was the pre-operative 63 micron average. This is the
Please, Dr. Rami, mute the microphone.
And you can clearly see the shape of the epithelium. So the epithelium is amazingly important. So as good as we hope INNOVEYE is going to be, is INNOVEYE is using literature references to calculate the expected epithelial remodeling, but at the end of the day, there's still going to be individual variation. So epithelium is super important. So what I've learned over the last few years having mappers is you cannot really repair corneas following previous surgeries without regard for the epithelium. So there's my second last slide. INNOVEYE is using more data, less subjectivity. It's the ultimate personalization, both on the diagnostic side, that information, and then the way you transfer it to a treatment. The beautiful thing about this is it's as simple as wavefront optimized. You have the device measure the eye, it gets sent to the laser, and it takes you 30 seconds to load up the treatment, and you shoot the result. So listen, thank you so much for your attention. I'm happy to answer any questions as far as I can. And yeah, thank you.
Thank you. And thank you, Arthur, for this great presentation.
Thank you, Hossam.
But you promised me that it will be easier. There is not a lot of complicated physics. But actually, you started that with a complicated physics about ray tracing. I wish if you could simplify it somewhat about the difference between the topography guided and the INNOVEYE.
Hossam, sorry, it just, you dropped off the last 30 seconds. Won't you just repeat that, please?
Okay, the ray tracing may be like the wavefront guided ablation. It's somewhat different than, it's completely different than the topography guided ablation, which is previously introduced by the Wavelight 2. Yeah?
Yes.
Did you get my point? Yeah.
Yes, I understand what you're saying. So historically, the easiest treatment to do is one where you put in the refraction and shoot the refraction. And that's a wavefront optimized or an aberration free. But you're not addressing higher order aberrations.
Yes.
Then wavefront guided treatments on some platforms are very straightforward. You do an eye design, shoot the treatment, and you get a better result than you would with a standard treatment. On the Wavelight platform, we know with the wavefront, you couldn't always do it. It was a different technology. It was quite difficult to do. So it never really fell into great use. Topography guided is fantastic, but it takes a lot of thinking on the surgeon's behalf, because when you do a topography guided treatment, you change the ablation profile with topography data, but you then have to do the calculation as to how is this going to change my refractive input. So there's a lot of subjectivity, and we have different things. We have TMR, and there are all kinds of ways of trying to calculate this. So that's why 4CDs has come out. I don't know if you've seen 4CDs from Mark Lobanoff. It's a very nice program that allows you to do a topo-guided procedure more predictably. So what's so nice about this and what makes this so easy is the patient sits in front of one device. The one device measures the tomography and it measures the biometry. That data gets sent directly to the laser. You walk to the laser, you go through that video that I showed you. All you do is you validate that the wavefronts are good, you validate that the topography is good, and you validate that the A scan is good. And it does the calculation in 20 to 30 seconds, and you go. And now you, in that time, you're doing a very, very customized treatment, but it's taking you no longer really than an optimized treatment. And you've taken away subjectivity. So it's no better red, better green. You're not about the patient's objective refraction. It's almost using a wavefront refraction. And why it's so much easier to do than the previous wavelight wavefront guided procedure is this device is using a Hartmann-Shack wavefront within INNOVEYE. The device that does the measurements is called SiteMap, and the SiteMap has a Hartmann-Shack, where wavefront traditionally with wavelight was done with a churning system, but this is done with a Hartmann-Shack.
Yeah, okay. But actually, we may face a problem with the old customized ablation mode, which is the tissue eater, that they are tissue eater. Especially, you showed in your presentation that the INNOVEYE may use 30 micrometer ablation. At the same time, the wavefront may take just 20. I think it's a problem. It could be solved.
So I think what every surgeon is doing is
And
when
actually,
they do
excuse me, what's the cause of that? Firstly,
well, because it includes tilt.
Excuse me.
So what INNOVEYE has different to any other treatment, it includes tilt as well as the higher order aberrations. And believe it or not, on some treatments, INNOVEYE is less. So it depends on the actual eye, how much tilt there is. So you know the lower order errors we traditionally speak of as sphere and cylinder.
Yeah.
But below them is piston, which is how far is the optical interface from your eye. That's called piston. And then the second thing people are talking about is that interface angulated, and that's called tilt. So tilt is included in an INNOVEYE treatment. And in some cases where there's a lot of tilt, it makes the ablation deeper. So what we do as a routine, because we're getting to learn the software now, is we load everything. It takes us about 2 minutes to compare an Oculink to a Contura, to an optimized, to a custom tube. We load them all very quickly, look at the ablation depth, and for most treatments, they're very, very similar, within a few microns of one another. But every now and then, there'll be one INNOVEYE that's definitely more. And if you go and look at the aberrations, it's always about tilt. It's always about tilt.
Yes, okay. Dr. Mohammed, I think you want to say something.
Yeah, I want to ask Arthur some questions. Arthur, first of all, I thank you very much for this very nice lecture, because I had a lot of questions about the new iTracy guided system and how it works. You know, of course, that I'm a fan of a die-hard fan for the wavefront guided ablation.
I know,
and I have. Yeah, I have many working with an iDesign system. I have a lot of problems. For example, that I can't treat the higher order aberrations alone. For example, can you treat them by this system alone, leaving the sphere and cylinder in its place? I mean, talking about the higher order aberration just for highly irregular corneas and so on. Can you do that?
So you know what? That's a really good question, and I've never tried that with INNOVEYE. I don't know if you can. But I think what I would do, Mohammed, in a case like that is I would do a topography guided with no correction and just do the high order aberrations and then look again in 6 months. That's how I would manage a very tricky cornea. On a very tricky cornea, I wouldn't try and do INNOVEYE. If it's a really aberrated cornea, I would do a zero powered topography guided just for regularization. And I would do it trans-epithelial so that you get the benefit of the epithelial masking as well. And then look at INNOVEYE as a later procedure. That's a super question. And I know we can look at the ablation, but I don't know that we can deliver a treatment with no refraction. I must try. I don't know. It's a great question. I'll try that.
Yeah, you know, because I am working a lot with the post-corneal cross-linking keratoconic eyes, and in those corneas, sometimes you face some corneas which are ultra thin, and you want just to regularize the central part of the cornea, or just to take out the noxious coma, just to modify the tilt in the central part of the cornea, and to prepare your patient for another procedure like a phakic IOL, for example, an ICL. So, of course, with an eye design, I have a limited, what's called physician adjustment, is to take just 2.5 up to on, but sometimes I need to take more, or sometimes I need to take off all the sphere, and just to keep the higher order aberration. This is my first question, and obviously we can work on that later on with your system.
So that we can do with Contura. We can for Contura or Oculink. So either shine fluid derived treatment or a Placido disc derived treatment, we can put in zero refraction. So for those cases, I would typically do that. I'd make the optical zone quite small to save tissue, and then do an ICL, just like you.
Oh yeah, that's good. And
Save
second,
tissue.
yeah, what about the accommodation of the patient? Because again, with the eye design system, you can find a patient who's highly accommodating, and you have to adjust the sphere. I mean, do you have this problem, or you take immediately the spherical error of the patients as for granted, because it is much more precise with the eye trace system than others? I mean, than even your subjective refraction.
Yeah, that's a really, really good question. And I don't have enough evidence yet. I've done like 46 eyes, I think, and I'm still learning, so I just don't know. So you're right. What we used to do in the past for wavefront was do a dilated cyclopleged eye. So that was the problem. You're getting an unnatural state, higher order aberration. And we always said, as wavelight users, well, you can't really use a wavefront that's in an accommodating eye because you can get some accommodating errors. But this one is actually using a churning system in an eye that is accommodating. It's not dilated. The pupil is dilated only by darkness. So it's done in a dark room with a towel over your head. So it's very, very, very dark. And our biggest failure would be that probably 15% of eyes, the pupil doesn't enlarge big enough for us to be able to get 6 millimeters of optics. And at the moment, we're only doing this treatment if we get 6 millimeter optical zone, because the software can extrapolate that to a 6.5 optical zone, and we want to do a treatment at 6.5. So the way it works is very interesting. Is once you have the virtual model eye, so here's your eye, it's 26 long, it's got a cornea of 47, and it's got whatever, and it now generates a treatment. And in that calculation profile, what it does is it does a virtual treatment of what it thinks the perfect ablation is. It then does the treatment on the model eye. It then looks and sees, are all the light rays converging on the macula? If they are, that's your ablation, and it'll load it up for you. If they're not, it then does a reverse ray tracing and says, hey, there's some rays that aren't perfectly on the macula. What do I need to do on the cornea to bring them on the macula? And so it does this iteration process. And I think because of the iteration, we're probably going to find that accommodation plays less of a role, because it's taking into account where the lens is, how thick the lens is, what the length of the eye is. So, but it's a super question. And it's always a question we've had. If you don't cycloplege, aren't you going to get accommodation errors in your information? What do you find on the eye design? Do you sometimes get accommodation errors?
Yes, of course. I mean, in the eye design, I usually go for the following. When the eye design gives me numbers with hyperopic eyes, I take it for granted because it has a very wonderful fogging system. For example, sometimes I measure that not the subjective refraction, of course, especially in young patients, but even in the cycloplegic refraction, and I found it, for example, plus 3.5. But when I go to the eye design system and the patient is not on cycloplegic, and of course in dark adapted one, and you measure the eye design system and you find that the wavefront refraction is plus 3.9. So I take the 3.9 immediately. Even he's accommodating. It cannot deceive you. in the hyperopic eyes, right? In the myopic eyes, it deceives you a lot. You might find that the myopic error is adding from 1 to 2 diopters. And then I go back to the clinic, I take the patients and I start to do a subjective refraction for him. Because with the myopia, I am very keen not to overshoot. And sometimes I overcorrect if I reply. That's why in the eye design system, it's a good system, by the way, to measure the higher order aberration. But again, the crossovers of the lenslets can give you a higher accommodation error, and you have to adjust what's called the physician adjustment. You go back to the subjective refraction, and then you modify the spherical error. And I never play with the cylinders with the higher order.
Excellent, good, great feedback. Mohammed, your microphone is muted.
No.
You hear me now?
Yes.
Okay. So we're looking to your results, because I am very interested to know the results of the accommodation on the spherical power in those patients.
That's a good point. So are we. That's I want to give it time. I'm pretty happy with the results at the moment, but it's early days, and especially on this profile that takes into account the expected epithelial remodeling, we have to give it time.
Yeah.
And see what it goes.
Yeah. In those cases of the, this is another question, the epithelial remodeling that.
Mohammed, sorry,
I
your
don't know
sound is
how
gone
it comes,
again.
but yeah, you can hear me now.
Yes.
The network was unstable, so you can ask your question again, Dr. Mohammed.
Yeah. Do you hear me, Arthur?
Yes.
Yeah, I was commenting about the epithelial remodeling after PRK, and I think this is one of the greatest problem in our PRK patients, not only for the primary corneas, but in particular also for the previously operated corneas. So why not for this kind of patient? Why not you lift again the flap and you do a LASIK redo instead of PRK?
That's a very good question, but many a time it's already the LASIK flap, because it's from 20 years ago, was 160 microns thick with a microkeratome. You don't have enough residual stromal bed.
Yeah, it's true. It's true until we find a solution for this epithelial remodeling, but it plays or we calculate a formula to adjust it in our treatment.
Exactly.
But still we don't have this. Oh, it was really interesting, Arthur. We're looking forward to your results. It's very interesting and encouraging at the same time.
Yeah, it's nice. I like it. For me, it's what I like about it, really. If I look at the last number of user meetings we've had, the last 3-4 years, every last user meeting was dominated by people's different opinions of how to do Contura. I do it this way, I do it that way, I do it that way, I do it this way, and it's just noise. And what I like about this technology is just like eye design, is if Mohammed Shafiq is doing it, or someone is doing it there, or someone is doing it there, you know what, we're doing the same thing. And I think when we start using the same parameters every time, we can start comparing and learning more. So that's what I like about it, is if I measure this patient, or you do, or Hossam does, with the same device, we're going to get the same measurements. And that means we're going to be doing the same treatment. And then you can start improving things. When everyone's got their own recipe, it's a lot more difficult to figure out how to make things better.
Yes. Well, actually, in fact, the eye design has its own recipe also, because when I teach how to use the eye design, I still have some tricks, like the tricks of accommodations that I told you about, and the tricks when you treat an irregular cornea or a previously operated cornea, like a previous LASIK cornea or so on. But still, these kind of recipe or instructions or guidelines are much less than those of the Contura vision.
Exactly. But I think, you know, it's just the way it is. You look at any country in the world and you're going to find that there are a lot more people that are treating first-time eyes. Everyone's doing that. But it lands up in the hands of a few experts of how to manage the complications. So on the complication front, that's okay. There are a few people who really know what they're doing and they can take care of that. What I'd like to see, though, is someone having a procedure done for the first time, getting a really, really good result with no long-term complications down the road. And then vision correction will grow. You know, get more, if you get more and more and more good cases, you're going to have more patients saying, this is the best thing since sliced bread, you must have it done.
Oh, that's great. We're looking forward to the next user meeting, and I hope to be face-to-face, not on online. I mean, we're not sure when they're going to release us from our homes, and are we going to have some real meetings instead of the virtual meetings again?
I'm sort of thinking that for me, the next real meeting is probably ESCRS. In
October.
Yes, I think so.
Yeah, hopefully that things will go better to allow the aviation traffic and the airports to open again, because I think the solution and the answer now is in the United States of America, because they have an exponential increase of numbers of cases in a way that is hilarious, and we don't know what's going to happen there.
Exactly. And you know, almost all of the airlines are basically bankrupt at the moment. So how and when they start flying again, who knows? It's a crazy world right now.
Yeah. Yeah.
I
enjoyed your talk very much. I think it's time to go. And
good luck for tomorrow.
See you soon. Yeah.
Thank you.
Have a great.
Thank you, Dr. Muhammad.
Thank you so
much.
Thank
you for your good and to the point question, Dr. Muhammad Shafiq. You actually asked the questions which I thought to think about the eye design, accommodation effects in refraction, which I was facing all the time, and going back to the subjective fraction as you are doing, sir. And let me to ask Arthur again before going to the bed. Again, about the customized ablation, do you prefer the PRK than LASIK, or you find that we can do a customized ablation in LASIK as well? Which is better?
I don't think
away from redo cases, in the version cases. If you are going to customize the ablation, do you prefer the PRK? And the second question in the first one, the PRK by epithelial removal, manually or alcohol assisted, or trans-epithelial?
So it depends on how regular the epithelium is for a first-time procedure. If the epithelium is very irregular, you can do a trans-epithelial procedure with a very good result. If the epithelium is very irregular, but overall the epithelial power is quite regular, then you can also do a trans-epithelial and you'll reduce corneal aberrations. But if you find that the epithelium actually has a power, and so then it becomes more difficult to predict exactly what it's going to do when you do a trans-epithelial. So as far as epithelial remodeling goes, what I've looked at over the years, and we've looked at, we're doing enhancements now from cases that were done 20 years ago, and both previous LASIK procedures and previous PRK procedures and previous RK for that matter, all get epithelial remodeling.
Before skipping this point, what's meant for general, for us and for the general audiences, what is the epithelial remodeling? What meant by this word?
Okay, so the normal epithelium is close enough to 55 microns across the entire surface of the cornea.
Yeah.
And if it's 55 microns everywhere, you can consider that being a zero power contact lens. It's like wearing a zero power contact lens. Pop it in your eye now and you can still see. But if you have, so what remodeling is for a myope is you've got a cornea that used to be steep in the middle. You now do a treatment that flattens the center. And over time, the epithelium gets thicker over the center to try and bring back some curvature. So now the epithelium in the middle, let's say to make it easy, is 70 microns, but the epithelium at the edge is 55. If you're now going to do a treatment that's trans-epithelial and you put in a correction of 55 microns, it's going to break through the epithelium at the sides, but in the center, by the time you've finished your PTK element, there's still 15 microns of epithelium.
Yeah.
Now you do your correction of -1, but your -1 is doing a hyperopic treatment because it's being masked in the middle. So even though you treated a -1 patient, expecting the patient to go to 0, the patient goes from -1 to -2. And you're saying, how did that happen? I put in minus, but the person's become more minus. And that's because of the epithelial map. So the epithelial map is extremely important. If you start doing complicated repair work, you simply cannot do it without epithelial mapping. Otherwise, you're going to get massive surprises. Massive.
Yeah, okay. So you mean that we according to the epithelial regularity and the thickness all over the area of ablation, it will help the precision of the results. But actually, if it's as expected with the platform epithelial thickness, it will be much better than creating a flap to do customized ablation after creation of the flap, because some thought that the part of the flap is also responsible for the corneal aberrations and the corneal related high order aberrations. So when you elevate them, when you lifted the flap, you do customized ablation on the bed. So you will reposit the flap with its effect in the high order aberration again. So the results will be much under expectation.
So Hossam, what's interesting about that, yeah. I would also believe that all the years, that potentially the flap may introduce aberrations, but funny, it doesn't introduce much aberrations. What the flap introduces is scatter. It's got the ability to introduce scatter, and so it may reduce your contrast slightly, but I can't tell you with any conviction that a PRK will do a better job of a customized treatment than a well-performed LASIK. I don't think so. I don't think so. But it's, look, it's early days. We're visiting a clinical trial at the moment comparing one-eye manual PRK to one-eye trans-epithelial PRK and looking at the aberrations in the cornea specifically. But the trial's been, delayed by COVID now. It's not
okay, but
COVID.
I think Arthur, this will be different with ray tracing based customized ablation than the topo guided, because the ray tracing translates the high order aberration from whole the eye as one unit, not related to the corneal surface itself. Okay,
exactly.
but all the time we have heard about the golden rule of correction, which is the transepithelial PRK with customized ablation, which is the best chance for the patients. Finally, and I know that you want to go. Also, Dr. Muhammad Shafiq wants to go again to about the PRK in the redo cases. What about the haze? What about the post-operative haze with you?
So it's really important. I have this conversation all the time. You know, I came from South Africa. I'm a South African, and I've been living in Ireland now for 22 years this summer. So where I am in Ireland, we don't see the sun all that much. Haze on top of a LASIK we never see it. But you have more sun in a week than we have in a year. So of course it's a different story. So exposure to ultraviolet plays a very big role. So I can't speak as an international expert on this topic. On PRK, I can speak about the Irish experience or the very northern countries' experience. And there it's simply not a problem. We routinely use mitomycin anyway, because it's so safe on the cornea.
Okay.
We routinely use mitomycin.
Okay, but I have reported no cases almost in the PRK without the primary PRK, but reported around 50% with the PRK in the redo cases, PRK on top of flap, not the primary surgery. What's your opinion on that, and what's the opinion of Professor Shafiq too about that?
Mohammed, you go first.
Yeah, I never do, actually, because of the same experience that he experienced. I got a lot of haze, even with the use of the mitomycin C, if I do it over a flap.
Yes.
For this reason, I am refraining since a very long time of doing a PRK on top of LASIK, because it gave me a hell of a time. This is the worst haze that I have ever seen with a PRK, is to do with a redo PRK on top of a flap.
So
Yeah.
I had the exact same experience in South Africa. And then when I came to Ireland in 98, when people were wanting to do it, I said, no, you'll see too much haze. And then a friend of ours, Ray Stein in Toronto, at a meeting spoke about having done 18 eyes of PRK on top of an old LASIK. And I said, but whoa, what about all the haze? I said, no haze, we're using mitomycin, no haze. And I said, but I've tried this before and we had loads of haze. And he said, and then we started looking at the ultraviolet exposure, and following Ray's advice, I started doing it slowly but surely. And now I have zero hesitation in doing it where I live. It's just not a problem.
Yeah.
Where you live, very different story. You guys are the experts.
Yeah, even in doing the PRK on the flap, the same results as the primary procedures.
Yep. No more haze. Not in Ireland.
Okay, but we have doing the same technique and the same concentration and the time of applying the mitomycin C. But
Yes.
Unfortunately, me and Professor Shafiq got a lot of haze. Yeah.
Yeah, because
No,
of
but that's
that.
because of the UV.
Yeah. Arthur is more lucky.
No. I think this is a question of ultraviolet and exposure to sun. Because of that, there is a difference between the countries and the areas. And it's as a matter of fact, my rule is whenever I don't have enough residual stromal bed, I do resort to another technique. I mean, physic IOL or something like that to treat for the retreatment. So if I don't have this, I go for another treatment, but I don't do any PRK over flap.
Dr. Mohammed, Dr. Arthur, did you do a femto flap on top of microkeraton flap in redo cases?
I have not done that because I've heard from too many colleagues of doing another flap, and you suddenly find out you've got two interfaces and people get all kinds of aberrations from that. So I tend to, for a flap that I can't lift, rather just do a PRK.
Yeah.
But Mohammed's got this right, is you've got to be thinking, Hossam, that it's LASIK is the same whether you're in the North Pole or the South Pole or the equator. But PRK is very, very different if you are on the equator or far away. So PRK is geographical.
Right, I agree totally. And regarding the lifting the flap, I lifted a flap for the oldest one I lifted was 17 years. I didn't find any problem to really lift a flap at any time. It never heals. The only trick is just to define the cleavage line where you're gonna put your spatula to disrupt the flap, and you do the flap rexis, but it's very easy and simple even after 17 years. So I don't find any reason to do a femto flap over a microkeraton flap.
Yeah, it is not logic, but actually, you know, sir, I have heard it and watched the video for one of our professors or our colleagues here in Egypt. Showed in this video a femto flap on top of the microkeraton flap with 160 by the OCT measurements of the flap thickness. And unfortunately with him, the procedure was good. But when I went for that, it was the first and the last. I got two flaps, femto flap and the older one. So it was horrible. And I stayed at home for 1 week after without any work. Because it was horrible. I got two flaps. I got two flaps. What can I do? To ablate on the recent one.
Yes, disaster. Yes.
Yeah. So just to lift the flap or do PRK or to shift to the intraocular lens or physic IOLs is much better. So the talkings to the experts is non-stopping, is non-ending. So I will finish by two questions from other participants with us. Dr. Rehab Tharwat is asking about the PRK in the high myopic errors and which degree you can do. Up to which degree you can do from the in PRK for myopic errors.
We did a paper in 2010, the AAO. It actually won the best paper of the session on comparing LASIK between -8 and -12 back those days to PRK between -8 and -12. And the results were very, very similar. So on a laser that has a big wide ablation profile with a big optical zone, you can do it up to minus.
Sorry, Arthur.
Sorry?
The results was what? Sorry?
Very similar. Very similar.
Similar, okay.
Similar.
Yeah.
So, but as we've said before, remember what Mohammed and I have both said. You can't do a -10 PRK in Egypt. You'll be in major trouble. But you can in Finland, no problem. You can in Ireland, no problem. You can in Canada, no problem.
Even -8. Even up to
up to -12. Up to -12. So today, because ICL is so good, we rarely go over -9, we rather go in ICL. But sometimes, even in a myope, you find you don't have enough space for an ICL, and they're too young for a refractive lens exchange. So we'll then do a PRK in a -9, yeah.
Yeah, Dr. Mohammed, what's your opinion, sir?
I agree totally, because again, as Arthur commented, it's geographical. PRK is geographic. So I never go beyond 75 micron ablation. I mean, whatever the situation is and the cornea is encouraging, I mean, anatomically, but the reaction to the PRK and the haze, it could be a disaster.
Yeah.
So I never go beyond 75, especially that we have a marvelous tool for high myopes, which is the ICL. Why not?
Okay, yeah, you can agree with for up to -6, around -6, if the cornea is okay.
Yes, it's around -6. It's I mean the maximum depth, again, coming back to the maximum depth, 75 microns of ablation using the mitomycin C. Afterwards, I'm in a great fear of inducing this kind of haze that might be very difficult to treat later on.
Yeah, okay. We also have to consider the residual stromal bed and the PTA, the percentage of tissue altered in PRK, like in LASIK too, because of the restriction of the biomechanical properties and the corneal hysteresis, right?
Actually, PRK is safer to the cornea, of course, mechanical-wise, but we're not speaking about mechanics only. Again, in the high myopes, again, if you lower your central K readings below 33, you're gonna get a poor vision. Again, if you are having such a nice tool of a phakic IOLs that they are improving and talking specifically about the eyes, why not to save the headache and go for it?
Yeah.
Why to go for a PRK, which is not
to save the patients and you save yourself first from the peripheral aberrations and the bad visual outcome after. The time of ablation of the mitomycin is depending upon the amount of error, or the same for 20 seconds?
No, it's fixed for me all the time. It's 20 seconds.
Arthur?
We do 0.02% for 30 seconds routinely. And if we do a hyperopic PRK, which is uncommon, we would go to 40 seconds.
Okay, is PRK satisfying for the hyperopics?
Yeah, I don't do many. And one day someone asked me how many we did, and I said, no, we don't do many, but I keep all my results on IBRA, on an outcomes analysis program. And I found we'd done something like 80. I couldn't believe it. So I went and looked at the results, and they were remarkably good. Very, very good. So I think we underestimate PRK and how good it can be. But even in Ireland, a hyperopic PRK generates more haze than what myopic does. Myopic at -8, we don't see haze. At -10, we don't see haze. But hyperopic +3, +4, you'll start seeing a bit of haze, even in Ireland.
Yeah, okay. The final question, please, for the recently joining participants, the INNOVEYE and the topo-guided ablation profile with the cross-link, and we are now with the cross-linking experts. To do the Athens protocol, which is a combination of the topo-guided ablation or INNOVEYE ablation together with the cross-linking, the topo-guided is better for that, or to use the new software and the new program?
I know how Mohammed does it. He'll tell you in a second with these wavefront.
Yeah, okay.
I tend to do these cases with topo-guided with no power.
Yeah.
Topo-guided, 0 power. So using the minimum amount of ablation and try and regularize the cornea as best possible, and then do the refractive error with a ICL or, in fact, Jorge Elliot told me an interesting trick. He says for a keratoconic with astigmatism, he doesn't like using an ICL because he thinks they move a bit more because of the shape of the eye. So he uses for those cases, he rather uses an artisan or a Artiflex or a Verisize. But I'm so happy with the ICL. I haven't used an artisan for a long time.
Okay, I'm asking this question because the newcomers, because it's very important, the crucial point, but to do, Dr. Mohammed Shafir, to do the cross-linking in the same session or to make it later?
You know, Hossam, that I stood a lot on the podium everywhere, criticizing the simultaneous protocol. Yeah. And for me, simultaneous protocol is totally, is totally obsolete now, because you don't know the effect of the corneal cross-linking if you do the simultaneous things. This is number one. And number two, the problem of the delayed epithelial healing that you are gonna get because of you insult the cornea double time when you do a corneal cross-linking and a PRK at the same time. So what I'm doing now, and I published my protocol, and I'm now about to publish the results of 3 years of follow-up, because the first publication was the first year, is to do a corneal cross-linking first, wait for a year, and by doing the corneal cross-linking, you improve the quality of the cornea that's going to receive your treatment afterwards. And then you go and do a wavefront-guided PRK with mitomycin C. That time, or this time, you're going to get better results in regularizing the cornea. It's going to be well controlled regarding the visual acuity. And if the patient has a low sphere and cylinder error, you might get very near to the emmetropia. So it's much very ideal than using the simultaneous protocol. So I'm refraining totally from doing the simultaneous protocol nowadays.
Okay, Dr. Arthur,
I haven't used the simultaneous one for maybe 3-4 years now, because you're right, Mohammed, it's a double insult. There's a lot of delayed epithelial healing. I've been doing something for the last 3 years, which is very, very surprising. I learned it from David Lin in Vancouver. He's done about 1,200, 1,300 cases like this, where we do it in the reverse order. We do the PRK first. This is in early keratoconics, not grade 4 or grade, but early keratoconics. Do the PRK first as a transepithelial PRK. So the epithelium now is in fact helping you do a very nice regularization of the cornea, plus you do the correction. And then we do an epi-on crosslink anywhere after 6 weeks to 3 months. Once we really like the result, we might do epi-on. And I have a group of patients. Epi-on,
yeah.
Yeah, because with epi-on, you get a cross-link, but you don't get any refractive changes. It's very neutral in terms of refraction, because it's a bit of a weaker cross-link. But here's the crazy thing. Listen to this, Hossam. You won't believe this. So we have a group of patients where we've said, we will cross-link you if and when we see your cornea steepen again. And I have many of those patients now at 3 years. 90% of them have yet not had their cross-linking. They've only had the PRK, topo-guided transepithelial. They've stopped rubbing. They've improved their vision, and their keratoconus has not progressed. So, of course, if the keratoconus progresses, we'll do the cross-linking, epi-on, but 90% of these patients, the keratoconus is not progressing. So, it's a very interesting approach. I like it.
Oh, that's interesting. I would like to see these results. I mean, the only challenging point in it is the progression of the keratoconus. And I think it's a question of many things. Number one, the age, and number two, the sex. Because in our country, again, the keratoconus should be tackled as an inflammatory disease and racial disease also, and it carries a lot of genetic factors and environmental conditions at the same time. And keratoconus as a disease, it's not a single disease, it's many diseases. I mean, a keratoconus for a lady is different from a keratoconus of a man. A keratoconus for children is totally different from those of adulthood. Still, you can find some subgroup of cases when you do a PRK for them and they never progress. I agree totally. You might refer to this kind of patients. So I'm really interested to see these results because, again, it goes with my way of thinking that you don't do the double insult.
Not anymore.
You do PRK and corneal cross-linking simultaneously. This is highly insulting to the cornea.
Exactly.
Yeah.
Okay.
I'm glad to hear this opinion from you, Arthur.
We are in front now of two opposing opinions, but we have to take the like a tailors to put the individual medicine, individual decision for each patient.
Yes, right. Well, yeah.
Okay, there's a more question from the audience, please. For Dr. Arthur, if epithelial mapping is not available, does PRK work with epithelial removal, which ablation provide for hyperopic patients and to which diopter?
So if you don't have epithelial mapping, you can't go very far wrong by using 55 microns for your PTK. They say the likelihood of the epithelium being 55 is more likely than the person's blood pressure being 120/80. So that's how predictable it is. But we do see some variation. But
we can use OCT instead. I think we can use OCT measurements for the epithelium instead if we have anterior segment OCT in the same time.
Yes, we have that device. But if you don't have that device, if you don't have it, you can put in 55. You're going to get a surprise on retreatments. The retreatments, you have to be very careful.
Okay, but I think soon it will be popularized because we are talking a lot today about the epithelial mapping for the diagnosis of the early cases of keratoconus. Especially today we have a meeting on the ophthalmology web meeting by Dr. Rifai from Morocco about the epithelial mapping and diagnosis of keratoconus in the normal corneal topography. Almost normal corneal topography with abnormal epithelial mapping, he could detect early case of keratoconus by this. So
absolutely,
we have to get a lot about it now. Okay, we have a lot of questions, but I think you are tired now, and you need to leave, right?
I need to leave.
We need another meeting for the questions. Another meeting for the questions.
Let's do another one. It was very good. The questions are great. Good luck for tomorrow, Mohammed.
Yeah. Excuse me?
Good luck for tomorrow's lecture.
Oh, thank you very much. Thank you very much.
So
it was great meeting you today.
Thank you by your presence here, by Dr. Arthur and all participants. Thank you very much for the international experts for the refractive surgery, and you are teaching us all the time, and we have a lot of benefits and information from that talking. And my apology to my dear colleagues who sent a lot of questions on the chat. So I promised to answer these questions in the coming meeting, and I will announce about it. And I am pleased to announce about the meeting tomorrow of Professor Muhammad Shafiq with Professor Ambrosio and others tomorrow at 3 p.m. Cairo time. Right, Dr. Muhammad? Okay. We will join, sir. And thank you, Dr. Arthur Cummings, for this kind and rich presentation and answers. And I will really, we have a lot of fans here, and so I have to arrange a break meeting with you, even the day after. And I'm sorry for the noisy mics with the others. Arthur?
Take care, guys.
Okay. Stay safe.
Thank you, Arthur. Bye-bye. Thank you, Dr. Muhammad.
Hey, pleasure, Mohammed. Thank you. Thanks, Hossam. Take care. Bye-bye.
Bye-bye, Arthur. Good night. Have a good night.
Good night.
Good night.